surgery and surgery of the thoracic spine. Also, Dr. Baaj is an active member of many international societies, such as the Scoliosis Research Society, the AO Spine, the CNS and INS Spine section. And the last and not the least, Dr. Baaj is an engaged and very important in international training, education in spine surgery all around the world. And he leads the annual continuous medical education courses on complex spinal surgery and spine tumors at Weill Cornell Medicine. So it's a pleasure to have him with us today, and we are honored and pleased to invite you. Please, Dr. Ali.
Thank you, sir. Thank you very much, and good afternoon to everyone and to all my wonderful colleagues and friends in Morocco and the entire region. It's absolutely a pleasure to be here. Thank you, Dr. Mohammed, for the very introduction.
There is just, Dr. Ali, there is just a mistake. It's Abdel Samad. I think my son just changed it. So Abdel Samad, sorry.
Sorry, Abdel Samad. Thank you for letting me know. It's really a pleasure to be here with everyone. And my goal is to, colleagues here know me, I don't like to lecture. I like to just share some ideas and concepts that I hope that everybody will find very helpful. And what I will do is share my experience with the principles of spinal deformity. I will tell you that I'm a neurosurgeon, of course. This is a little bit about my background. I went to school in Boston University. I spent for some of you that don't know me, I spent most of my life in the USA, in Boston area. So I went to college and medical school there. And then I did neurosurgery training. And like a lot of my colleagues here, we very quickly know that if you want to be a dedicated spine neurosurgeon, you really have to do subspecialty training. And I was fortunate to do two spine fellowships, one in neurosurgery, one in orthopedic pediatric. And I'm very, very satisfied with the training, and that's why we're able to provide comprehensive services. One of my passions is, of course, education and training, and I'm heavily involved in AO Spine and SRS. So I'm going to get right to this. This presentation is for neurosurgeons. I'm a neurosurgeon. I like to talk with all spine surgeons, but I think the principles here apply to me and my colleagues in neurosurgery. Because this is what we do and this is what we see. This is a patient that came to me that was having a lot of back pain. And I said, okay, well, what did you have? And he said, well, first I had a L4 to S1 fusion, laminectomy and fusion. I said, okay, did your pain improve? He said, no, my pain did not improve. I said, what happened next? He said, well, I went to another surgeon, and the second surgeon thought that I had adjacent segment disease, degenerative disc disease, and the surgeon did a 2-level MIS lateral fusion. And here's the AP, here's the lateral, 2 beautiful lateral cages. I said, okay, did your pain get better? He said, no, my pain didn't get better. I said, okay. I examine the patient. It's the first time I see him. I examine him, and I see that he has an abnormal posture. And I do something very, very simple, very easy, and I think you should do it all the time. I obtain a standing scoliosis x-ray. And when I obtain the standing scoliosis x-ray, here's what I see. I really see more of a neuromuscular C-type deformity, and there is no question that his back pain will never help. It doesn't matter how many levels of fusion you do, his back pain will not help. And I think if the initial surgeon maybe looked at his overall alignment, he would or she would have noticed that correcting the lower back alone is not going to help this patient's back pain. So the first point of this lesson or this talk is really, especially for the trainees, the junior surgeons, is when you're evaluating patients for back pain, try to obtain a complete set of x-rays to know what the overall spinal alignment looks like. Even if you're doing a 1 or 2 level lumbar fusion, which we all do all the time, it doesn't hurt to see what the overall alignment is. You may be missing something, okay? So why is this important? Number one, we're doing more complex spine. We're not just doing T-lifts and laminectomies, and we don't want to cause deformity. I mean, let's be honest, in many parts of the world, including the United States, our orthopedic colleagues, and they're right, they have said, well, you know, you neurosurgeons don't study enough biomechanics, you don't, you know, take into consideration the alignment and the balance, and you're creating a lot of deformity. Now, you know, I can say they're over-treating patients because I think some of them do, but the point is they're right. We have, if you want to be a spinal neurosurgeon and dedicate your practice to spine, you have to be able to understand the overall global balance and mechanics of the spine.
Was some kind of depression that actually aggravated more the instability. So the only option for this.
Okay, sorry. So this is, so obviously everyone knows this. This is a review for everybody, but it's important. It's important that you assess the spinal balance before an operation. Now, the number one question that I get is, well, if you have a 75 or 78-year-old female and she's frail and she has very high risk, she's very high risk surgically, do you know, are you really going to do big scoliosis surgery on her? Probably no, but I want to know what it looks like because I can counsel the patient better on adjacent segment disease, the chance of back pain improvement, what's the future looks like. So yes, I do think it's important to understand it, even though you may not want to treat it all the time. And remember, the deformity correction principles are age adjusted. We now know very well that if you try to overcorrect, you're going to get proximal junctional kyphosis, PJK, and so you don't need to make every single 80-year-old patient stand up straight again. So it's age-adjusted correction. And this is a very important concept because even some of our colleagues, they're, okay, well, we get the x-rays, we know what the coronal deformity is, we measure the pelvic incident and the pelvic tilt, and everything looks good. Look at the spine. Okay, it looks good. The SVA is probably okay, but be careful of the pelvic tilt. You really should be able to look at the pelvic tilt carefully because if you have a very high PT, that can make patients perform a compensatory pelvic retroversion. It's called a false normal, okay? A false normal balance. So they may look balanced, but they're retroverting, or standing back, and it's a false normal balance. So be aware of the pelvic tilt and make sure you are measuring that. Now, so this is what we don't want to do, okay? Oh, we put screws and rods, we get the CAT scan, the x-rays, we're excited, we know how to put a pedicle screw and everybody's happy, but then we leave patients with flat back, we leave them with deformity, they're going to be happy for 6 months, maybe 1 year, then it becomes a bigger problem to treat. So this is one of my patients. This is a 70-year-old female who came to me with back pain and forward posture, lumbar stenosis. So you're neurosurgeons like me. We see the MRI. The first thing the patient comes with is an MRI. MRI shows lumbar stenosis. You think she needs a lumbar laminectomy, but then when you obtain the X-ray, you see that she has a significant mismatch between the lumbar lordosis and the PI. You see that her sagittal balance is off. She has forward posture and she has back pain. You decompress the neural elements, that may relieve neurogenic claudication, but the back pain is coming from the muscles that are working so hard to keep her straight. And her DEXA shows osteopenia. Never forget that DEXA scan is very important before surgery. So this patient was not going to do well with just a lumbar laminectomy. Maybe she will do well for 2 months or 3 months, but then her forward posture will worsen and her scoliosis will worsen. And for these patients, these are, you know, a lot of people say, when do you do 2-column osteotomies? When you do 3-column osteotomies? I will tell you this, and we have a lot of very esteemed deformity surgeons on the call with us here. like Dr. Ben Lahoud and others, you know, the trend in the United States is to do less 3-column surgeries, less PSOs, less VCRs because of the morbidity. And we're really trying to do a lot more PCOs, which are pontiostenotomies, Smith-Peak osteotomies. So if you see discs that are open, and if you see that there's no ankylosis or no fusion, ventral fusion, we really try to do the PCOs, posterior column osteotomies, which obviously have less morbidity and very good corrective power. And so that's what this patient did. I use that technique for both adults, like this one, and pediatrics. Young lady who has MED, posterior multiple epiphyseal dysplasia, MED, and she came in with progressive symptoms, progressive scoliosis. This is a syndromic scoliosis. And again, just through PCOs, you can very nicely do partial or sometimes complete correction, depending on the neural elements, with very, very good results. I do a little bit of pediatrics, as I mentioned. This is a double major curve in an 11-year-old female. Again, everybody knows how to do these. These are the Ponti corrections, the Ponti osteotomies with derotation techniques. And I have a video here to show. So once you do the releases, do the facetectomies and the PCOs, you can do either rod rotation and segmental derotation. So you can do both en bloc and segmental, and use the leverage of these new instrumentation to be able to achieve correction. This is the final result, a very, very acceptable correction of a double major curve. Now, I will also show you a video. This is, I don't know how many here use or like navigation. We do like CT-guided navigation. It's a little bit controversial in pediatrics, but we feel the safety is very important. And I'm going to just show you our workflow. This is a patient with a 42-degree curve, but it was progressive, and she had back pain. So we chose to treat her surgically based on her symptoms, not just a curve. And we have intraoperative navigation. And I like to do that a lot just to confirm. The screws go in without navigation, but the gear shift goes, this is the gear shift to cannulate the pedicle. I use navigation for this instead, especially in some complex deformity. And then this is how we correct the alignment with en bloc derotation techniques. Now, again, in pediatrics, the coronal balance is more important and the coronal Cobb angle is more important. In adults, the sagittal balance is more important. So you can have a patient, an elderly patient, if they have a mild coronal deformity, 20, 25, 30 degrees, that's acceptable. But the adults complain of the sagittal imbalance. So when early on, I used to take even adults, fix their scoliosis, their x-rays look great, but they're not better because they're still sagittally imbalanced. The kids, it's different. Coronally is what's more important for them. And you can use whichever implant system you want to use. They're all very good these days. Again, some syndromic patients. This is a young girl with a Klippel-Feil syndrome who had progressive scoliosis. And again, I'm not going to do a VCR or a 3-column osteotomy on a 12-year-old. I think we can get very good clinically acceptable results, radiographically acceptable results with posterior column osteotomies and a partial but very acceptable correction. So these are the kids. Going back to the adults, again, this is a patient with Parkinson's syndrome who had lumbar laminectomy infusion many years ago. She started to have thoracolumbar kyphosis, but she was flexible, and we know she was flexible because when you see the CAT scan or the MRI, you compare it to the upright X-ray, or you can get supine X-ray, you know that she's going to be a little bit flexible. So we do PCOs, Ponti osteotomies, and extend the construct to T10. Of course, this patient is high risk for PJK. Of course she is. All Parkinson's patients are at risk for hardware failure. So we will keep a close eye on this, but she has a much better sagittal and a much better coronal balance as well. So, you know, when I show these cases, especially to colleagues in neurosurgery, and they say, well, maybe you can get away with a short construct with lateral, you know, maybe 2 or 3 level lateral. I mean, I'll tell you this, and some of my colleagues here know this. I love minimally invasive spine. I do MIS TLIFs, MIS laminectomies all the time. But if it's a big problem, you have to do the big surgery. You can't take shortcuts. You just can't take shortcuts, or the patients are going to come back very, very soon. And this is her. We now know in deformity surgery, we're using MRCs, multiple rod constructs, 3 rods, 4 rods, very, very common now to use multi-rod constructs in these complex deformities. And again, so this is a patient, this is a perfect patient who has a mismatch. And you can see that she had multi-level stenosis. So if this patient has multi-level stenosis, she already has a coronal deformity, a little bit of a mismatch. Well, if I do multi-level laminectomy alone, the coronal deformity is going to get worse and the sagittal balance is going to get worse. So, so this is, you know, a little bit controversial, but I perform to do the fusion for this patient to protect the laminectomy, to protect the decompression, so she doesn't have post-laminectomy worsening balance. A little bit controversial, but there's a lot to be said about that. And again, this is a different patient. The things that I look for, SVA, sagittal, you know, you can look at 50 parameters. You can measure 100 parameters. The ones that I look at very carefully is the SVA, the pelvic incidence, the pelvic tilt, and the lumbar lordosis. That's for my lumbar degenerative deformity. For my cervical, I look at the angle slope, at the T1 slope angle, and the C2 to C7 SVA. But since this we're concentrating on lumbar, these are the things that I look for. It's very important to have the PI and the lumbar lordosis within 10 degrees and the SVA within 5 degrees. Now, those of you that do tumors, and I know, of course, surgery do a lot of tumors, don't forget, in pediatrics, when you do the laminectomy, multi-level laminectomy for tumor or for spinal cord tumor, if the patient is still growing, they're going to have a deformity. So you either do a laminoplasty, which is really only effective probably in 20 or 30% of the cases, or you do the short segment fusion. So this is a patient with osteoblastoma. She already had a 20-degree coronal deformity. You know the tumor involves the pedicle and the facet joint. So if you just do a laminectomy, that patient's going to have a very bad outcome. So I did a short segment fusion on her. So don't forget, deformity is not just degenerative process, especially for us neurosurgeons. We do a lot of laminectomies for tumor, for abscess, for infection. You have to consider that every case is a potential deformity, okay? Not just degenerative. I just showed this video because I like to, I've been, for patients with pathologic fractures, with osteoporosis, this is my technique now of using cement augmented screws. I place screws that are fenestrated, that you can insert the cement right into the screws. Before it used to be cannulate the pedicle, squeeze in some cement, then come back, take the screw, put it in. Now they have a lot of systems that have made this much easier to treat osteoporotic deformities. So in conclusion, my personal opinion, especially here for the trainees, remember to be principle-driven decision-making, not technique-driven, which means that if you're excited, and this happens to all of us, especially in neurosurgery, because I think we're very innovative. I think we like to trial new technology, which is perfect, but especially for the trainees and for the young surgeons, don't focus on the technology or the technique, focus on the principles, and then use the technology that you like or you want to try or you believe in to achieve your goals. But you have to respect the principles. In deformity, you have to look at the sagittal balance. Coronal balance is important. but sagittal balance is more important in adults. In children, it's the opposite. The coronal balance. It's the opposite. Look at the pelvic incidence and look at the pelvic tilt. And remember, don't forget the pelvic tilt, because if you have a high pelvic tilt, that means the patient is retroverting and they're trying to show you that they can stand straight, but they're really not straight. They're compensating for their deformity. And for those colleagues that like technology, like intraoperative navigation, robotics, I'm a big believer in all of that, endoscopy. I love technology, but use technology to shorten surgical time and minimize complications, not to just because you want to be the only person in Morocco or New York that uses this new technology. Make sure you use it to improve actually the patient's outcome. And finally, this is important for the trainees that are with us on the call. Like I said early on, if you have a patient that comes to you and you think they have a degenerative scoliosis, but you know what? They only have a radiculopathy. Their only problem is an L4-5 foraminal stenosis, radiculopathy, no back pain. They've had back pain forever. That's not their problem. Don't treat the X-ray. Don't do a big reconstructive surgery on a patient that's coming to you with radiculopathy. So the physical exam is important. The history is important. So know the X-ray, know what the overall balance is, but in the end, don't forget, of course, to treat the patient. We don't treat MRIs and X-rays, we treat patients. So I know I was talking for a long time. I want to thank all my colleagues and all my friends here on the call for letting me share what my philosophy is for treating degenerative scoliosis and some pediatric scoliosis. And I'm happy to let the hosts and moderators ask questions.
Thank you very much, Dr. Ali. It's a very nice conference. And I totally agree with your last point when you say you have not just to know about the X-rays, but to treat patients. This is very, very important. I have just one question while waiting maybe for the colleagues if they have any question. You are dealing with both pediatric and adult cases. And in your experience, it's very rare that you find that neurosurgeon or orthopedist doing with both. What was for you most interesting to start with pediatric and then to switch gradually for adults, or vice versa? The principles are so different.
Yeah, exactly. Thank you very much.
Please, Professor Ali, you can unshare your talk.
Oh, unshare. Sure. I'm sorry. Yes.
Thank you.
Of course. Thank you very much. That's a very good question. So I will tell you, as a neurosurgeon in neurosurgical training, as far as pediatrics, we did spinal cord tumors, we did cord untethering, myelomeningocele, and with all due respect to everybody here, that's not what I enjoy to do. I enjoy the complex spine. So from a philosophical training perspective, I knew that if I wanted to be a comprehensive spine surgeon, I needed to know pediatrics. And it's not easy, but you have to search for mentors. You have to search for people who are willing to train you. And so I think some of you know our colleague, Dr. Lutfi Miladi from Necker's Children's Hospital in Paris. He was actually emailed him, and he was very generous to let me spend 2 months with him in Paris. And actually, I exposed myself to pediatric orthopedic spine from him and his group in Paris. Because, when you deal with children, you as a neurosurgeon, you can treat adults and children, but you have to do what's safe for the patient. So I knew I had to do more training in specifically pediatrics. And that's why I'm interested in, that's why now I do both.
Okay. Thank you. Yeah, Dr. Azhari, asking Dr. Azhari. Professor Azhari.
Hi, Ali. How are you?
Hello, sir. How are you? Thank you. Good to see you.
Nice to see you virtually, as Hilmani said.
Nice to see you.
Long time since Dubai.
Yes.
Thank you very much. I want to thank you very much for your as usually clear and very interesting topic. I just want to ask you one question, because in 5 minutes I have EC meeting of French-speaking society as a general secretary. we have a meeting in few minutes, so I beg pardon to my colleagues to be the first to give you the two questions. The first is when you operate children, is the anterior approach is sometimes used, especially
the anterior approach.
Some cases. And then my second question is, but you said it very well. We have to treat the patient. Since many years, spine surgeons want to make the colon as young people. It's not possible to overcorrect. As you said, it's very interesting what you said. That is to see the patient and to see where is the problem and where is the angle which we can correct without exceed anything. And my question is, how many patients before 60 or 70 you treat in your experience? And thank you very much, Ali. And I want, before leaving, to thank Professor Wahabi, Professor Hilman, and all the AC meeting with spine surgeon of Spine Moroccan Society. Thank you, Ali.
Thank you, sir. Thank you, sir, for those questions. Very important questions. The first one is about anterior approach. You know, I think as many of you know and probably also see in your practices and in your regions, in spine surgery, we have like a pendulum, you know, the pendulum this way, sometimes this way. In the United States, I can tell you that the pendulum really is swinging towards posterior-based approaches with less anterior. Less anterior, and that's true, by the way, for trauma, that's true for tumors, that's true for deformity, because the instrumentation has allowed us to really control the spine posteriorly. The only exception to that is there's a big interest now in non-fusion VBT, vertebral body tethering, for scoliosis in children, which of course can only be done anteriorly. That's probably slowly, well, not slowly, I think it's rapidly gaining interest, and that of course is an anterior approach. But for the vast majority of deformity surgeons, I would say the posterior approach is the main go-to. Now, I will tell you an exception. As neurosurgeons, and I do this a lot in my practice, I like the ALIF procedure. I really like anterior lumbar interbody fusion procedure. It's minimally invasive, it's safe. And if I see a patient that I think needs a 3-column osteotomy to get the correction, in my hands, in my experience as a neurosurgeon, it's safer for me to do 1 or 2 level ALIF, obtain correction, and then go posteriorly without having to do a 3-column osteotomy. So the question is when do I go anterior? If I have to. If I have to, and it decreases the morbidity of a posterior approach, I will go anteriorly. And as far as the second question, you're absolutely right. Thanks to people like Dr. Lenke, Dr. Schwab, and these really giants in orthopedic degenerative deformity surgery, we know from them that we shouldn't overcorrect patients, especially the elderly, especially the ones with osteopenia or osteoporosis. You said it's not right to we don't need to correct them. I think it's almost dangerous to overcorrect them because you're creating potential, PJF and PJK. Sometimes you can treat PJK quickly, but if you don't, they can have a spinal cord injury at the proximal level. So yes, do not overcorrect elderly patients with osteopenia. It's never going to result in a good outcome.
Thank you, Ali. Thank you. I didn't know that you have been in France. You speak French?
No, I wish I did. That's the only thing I did. When I went to Paris, I either had to learn spine surgery or French language. I decided spine surgery.
Professor Hilmani.
Thank you very much. Thank you, Professor Wahabi.
Thank you, Mr. Wahabi. Thank you, Professor Ali, for this very informative and educative presentation. I try to be basic. We know that spinopelvic parameters it's very important to assist spine deformity. But my question, if these parameters, we use it for only evaluate moderate to important deformity, or to use it for decide how to treat this patient. Second point, these parameters, pelvic and lumbar lordosis evaluation, how we use it to evaluate perioperatively, and how we use it to correct the deformity. And thank you.
Okay, thank you. Thank you. That's a very important question, especially to somebody like me who's a neurosurgeon and some colleagues who do general neurosurgery spine. I will give you, Professor Helmani, a perfect example. If you have a 25-year-old female, 25-year-old girl, who comes to see you with a grade 2 or grade 3 spondylolisthesis, isthmic spondylolisthesis, right? We see this, grade 2, grade 3 spondylolisthesis in a girl. Depending on what her lumbopelvic parameters are, you actually, and this is based on Rasuli's work and others, you can actually, it changes what you do. You can either fix them in situ versus correction versus balancing them. Depending on whether they have a balanced lumbopelvic spine or not, dictates whether and how much you have to correct. So there are certain cases in which the lumbopelvic parameters will tell you what to do and what you shouldn't do. And what I gave the example is, that's a young girl. If I have a 75-year-old female who has chronic back pain, but only radiculopathy, and she has a little bit of lateral recess stenosis, it doesn't matter what her lumbopelvic parameters are. That person needs a minimally invasive laminectomy, hemilaminectomy, and she will get better. So the cases that I showed you are cases of younger patients, 50s, 60s, that's very young, right? They have multi-level stenosis, and their physical exam shows that they have forward, they have a lot of back pain. You have to measure the parameters so you know how much correction to bring, and so that you don't overcorrect them. If you have a pelvic incidence, normal pelvic incidence, if you have a PI of 55 or 60, and let's say their lumbar lordosis is 20, let's say they have a flat back, 20 degrees. Well, this will give you an idea that you need to give 20, 25 degrees of lumbar lordosis. So you have a good match. You have a good match between lumbar lordosis and PI. So in your hands, how do you get 25 degrees of lumbar lordosis? Do you do it with facetectomies and T-lift cage? Do you do it with A-lift cage? Everybody's different, right? You have your style, I have my style, but the lumbopelvic parameters tell you, number one, do you need to correct the deformity? And number two, how many degrees of correction you need to bring so you can bring them back in harmony, spinopelvic harmony. I'm sorry, I know that's a complicated answer, but that's how I use these. I use these parameters to tell me if I need to correct them and how many degrees I need to correct them. The lumbopelvic parameters don't tell you the technique. The technique is up to you. In your hands, maybe you like 3-column osteotomies, maybe you like front back. It just tells you how much you need to correct. And I know we have very good colleagues that do deformity surgery. They can also comment. Dr. Abilahoud, you do a lot of this, and we talked when you visit us in New York. What do you think?
Yeah, I'm totally right. You're totally right, Ali. I think that this story of spinopelvic harmony is very important. So, especially in elderly, we shouldn't overcorrect. So what we do here, and if we have a pelvic incidence of 60 degrees, we won't go for a 70-degree lumbar lordosis. We will accept the 50-degree, but if you have a 40-degree of pelvic incidence, we'll try to match with it. So the more important is the pelvic incidence. I think that the correction should be inferior to the pelvic incidence, because if you go up, you'll make major constraints on the spine and will break. So let's go, we are doing a study now in France with the SFCL, the French Society of Spine Surgery, trying to study the pelvic parameters across the ages. Okay, so now we have a big series of them, and we'll be able to say let's go for a 60, 70 years old. Those guys, they have a lumbar lordosis of around 50. We won't go for 60, even if they have a pelvic incidence of 60. So let's undercorrect in the population who has a big pelvic incidence, and let's normal correct for the pelvic incidence, which is, you know, low one, 35, 40 degrees of pelvic incidence. And the second thing, and I would like to share with you, I'm oral, you know, I'm okay with you for about that. A-lifts are very important. I don't know if you hear me.
Yes.
Yes, yes.
Are you still hearing me?
Yes, yes, yes.
Yeah, yes, yes.
Very
Yeah.
good. You can continue.
I think he was trying to say that, you know, the ALIF is a very important part of our armamentarium. You have to have a good approach surgeon. Very few people do it by themselves, but if you have a good approach surgeon, the ALIF at L4-5, L5-S1 is a very powerful technique to get correction and indirect decompression too. Any other questions?
Yes, yeah, Dr. Aitman Ali, Professor Aitman Ali, who raised the hand.
I'm sorry, but the connection went. I think that the connection was bad. So I'm sorry, but the connection, I think it was bad. So as I said, we finished with the correction, but here in France too, we use a lot of A-lifts, you know, when we have a loss of lumbar lordosis, and we know that lumbar lordosis is between L4 and S1. So when we go from, you know, a double A-lift, it will give you 30 degrees when you have, you know, flat discs. And then, like Ali said, we won't go from behind and do major osteotomies, because posterior osteotomies are, you know, even in good experienced hands, you know, there are major surgeries with big blood loss. You know, patients have neuralgia after that. They have, you know, in a big proportion of cases, they have weakness, you know, thigh weakness. So we try to adapt to each patient. Let's maybe undercorrect for the high pelvic incidence and use the A-lifts when we have major correction of lumbar lordosis. And that's it. Thank you, Ali.
Thank you, George.
Hello,
Thank
everybody.
You. Dr. Aitman Ali, yes.
Thank you very much, Professor Baaj, for this excellent lecture. Thank you, Professor Wahabi and Professor Hilmani. Do you recommend to perform preoperative spine CT scan for all the patients to check the pedicle, length of pedicle, diameter, especially for the malformative cases?
That's a great question. Thank you, Dr. Saeed. Thank you. It's a pleasure to meet you here. The question is, do you recommend obtaining a CT scan on every patient, correct?
Yes. Yes.
Okay. Yeah. So the answer, in my opinion, is you do not need a CT scan on every patient. The ones where you should have a preoperative CAT scan is number one, if they had previous surgery, previous instrumentation, because that's the best way to see where the ankylosis is, where the fusion is, where the non-fusion is, and if there is hardware issues. Yes. So that's number one. Or number two, if there is, of course, a significant congenital malformation where the bony anatomy is not favorable. I can tell you that in centers where there is intraoperative CT scan, now I do the CT inside the surgery, so they don't have two CAT scans, only one. But yes, the CAT scan role is limited, in my opinion, to patients who've had previous surgery or patients who've had congenital malformation, but not for every basic or simple lumbar degenerative case. I don't recommend a CAT scan routinely.
Thank you.
Okay, there is Dr. Nasiru Ismail from Nigeria who raised his hand. Dr. Nasiru Ismail, hi, how are you?
Yes, fine, alhamdulillah, sir. Thank you so much. This is an excellent presentation. And really nice to see you again, sir, and all the panelists. My question is about the guide for proximal fusion level and also the distal fusion level. That's number one. Number two is, do you place the screw via minimally invasive technique? And number three is the role of blood salvage during this surgery. Do you use some form of blood salvage? Because some procedure and sometimes there's a lot of
Great question.
Advice.
Great question. Thank you very much, Dr. Nasru. Thank you very much. I heard the last two questions. What was the first one?
It's the proximal fusion level, where you put the screw, the guide. Proximal
Okay. Yes.
level.
Perfect. So thank you very much, sir. It's good to see you. The first question is, what's your UIV, your upper instrumented vertebra? And it depends what the goal is. In pediatrics, for example, if I'm doing a pediatric scoliosis, they have say a Lenke 1A. Well, the UIV depends on their shoulder, right? Which shoulder is higher? And it's always either T2, T3, or T4. So high thoracic for pediatrics. If it's a Lenke 1A. If we're talking about lumbar degenerative deformity, most of the time we have to do pelvic fixation for a true deformity. Then in my hands, I'm going to the bottom of the thoracic spine, T10 or T11, T10 or T11. If they have a significant thoracolumbar kyphosis, not a lower lumbar degenerative deformity, if they have a significant thoracolumbar junction kyphosis, then I may consider going up. But the real way I want to answer that question is the other way. Where do I never stop? Where do I never stop? Unless it's a trauma, unless it's middle of the night trauma or tumor, but for degenerative deformity, for scoliosis, T5, T6, T7, sometimes T8. I don't like to stop or start at those levels, T5, 6, 7, 8, because they're very close to the thoracic apex, and those are not good starting points or lower points, the mid-thoracic spine. Your second question about MIS screws, as some of you here know me, I really like minimally invasive surgery. I do a lot of MIS C-lifts, MIS perk screws for trauma, for tumor. I don't think we have it there for complex deformity just yet. I know a lot of people are working on it, but I don't think we have great MIS options for complex deformities. Basic degen, trauma, tumor, I love MIS. And your last question is, yes, for complex cases, we use Cell Saver. We use Cell Saver so we can reuse the blood products. And we routinely use TXA or another agent to minimize the bleeding during surgery for bigger operations. I hope that answered the three questions to your satisfaction.
Thank you very much. Thank you very much. Excellent presentation.
Professor Abadi, she is raising her hand. Professor Abadi Najia.
Good evening, everybody. Thank you so much, Professor Ali Baaj. It's my pleasure to congratulate you again as President of Panorama Society, and we are proud to have a lecture as such you in this session. So my question is about the age. It's already about the age. In your opinion, there is a limit of the age for correction of the deformity, especially in degenerative? And the second one is about using the neuronavigation. I saw that you have used one of your slides. You have neuronavigation to put the screw. Did you use it every time, or in the beginning only? And the third question, the last one, is about neuromonitoring. Did you use the neuromonitoring always, or just in some cases? Thank you.
Thank you. Thank you, Dr. Najia, and it's a pleasure to meet you here. And thank you for the invitation with the other colleagues. As far as the three questions, I can tell you that the real answer to these questions is not what I do, but it's what does everybody do in New York? What does everybody do in Rabat and Marrakesh? That's really the answer to these questions, is what is the standard of care in your region, in your city? That's how we look at it. Intraoperative neuromonitoring in the United States, intraoperative neuromonitoring is the standard of care for complex deformity correction and spinal cord tumor, okay? It's not the standard of care for a one-level fusion or an ACDF or a posterior cervical, but we use it because in our system, in our region, that's what everybody does. So I know that's not a great answer, but you must use it. This is the US experience. You must use it in complex deformity correction, adult and pediatrics, and spinal cord tumors or unstable trauma. But for basic degenerative fusions, it's not the standard of care across the country, but more and more centers are using it. The answer to the other question is intraoperative navigation. I do not use intraoperative navigation for every case. Simple posterior cervical, simple ACDF, of course, non-instrumented. We do not use navigation for that. We use navigation for complex deformities, MIS. Navigation is beautiful for MIS. No fluoro, you don't have to wear the lead, but it's not used routinely for all the basic cases. And your very first question was, the first question was
age. Age.
Yes. The first question is relating to age. You know, just like every patient is different. Every patient, I have patients who are 40 years old, and they don't look like they are healthy enough to tolerate a big operation. And I have patients who are 70, who are active, they run, they play tennis, they play golf, and they want to stay very active and they're healthy. So the 40-year-old is not going to get a big operation, but the 70-year-old probably will. But in general, I think most would agree that once you're over 74, 75, definitely high 70s, you really have to think hard before subjecting them to a major deformity correction. I try to do the least possible and the most minimally invasive possible in my patients who are in their 70s and 80s. Under 70, and if they're healthy, I don't have a problem offering a major reconstructive surgery if they need it.
Thank you. Thank you so much.
My pleasure. My pleasure.
Thank you. Yeah, Dr. Adil Khalifa, he raised his hand. Dr. Adil Khalifa.
Good day. I don't know if you hear me.
Yes.
Yes. My question for Professor Ali Baaj, if I may. As a resident, we have always a confusion. What?
Dr. Adil.
I repeat my question. Yes. Okay. My question is about laminectomy and instability. We have a lot of confusion about that questions, because principle of spine biodynamics said that in laminectomy don't affect the spine stability. What is your opinion, Professor, please?
Thank you, Dr. Adil. The question was the effect of laminectomy on instability. That's a very, very important question. And I really think a lot of us know the answer to it. Because if you're doing a multi-level laminectomy on a patient that has normal parameters, no deformity, no sagittal imbalance, no coronal imbalance, no significant spondylolisthesis, and you want to do a laminectomy, that's fine. The patient is probably not going to develop instability, at least not soon. Now, if your laminectomy is very aggressive and you take a lot of the facet joint and you take the pars, we're going to have a problem, right? And that's why I just did 2 of them yesterday. I love to do my laminectomies with a tube. You stay medial, you can do foraminotomies, you don't touch the facets, you don't touch the lateral stabilizing elements, you don't touch the posterior tension band. So I converted my laminectomies to tubular to avoid the instability. Now, Dr. Adil, you bring up a great point, and I showed 2 examples. This is why I'm telling you, if you want to do a multi-level laminectomy on an elderly patient, sure. But if they seem to you based on history, physical exam, or x-rays, that their problem is more back, it's more structural, it's more back pain, it's more forward posture, then you have to investigate a little bit more. And I showed you a case that the patient had severe lumbar stenosis, but she had coronal deformity. She had sagittal imbalance and a lot of back pain. If I just do a laminectomy on that patient, they're going to have instability, they're going to be unhappy and have worsening posture. So the answer to your question is you don't need to put screws and rods in every laminectomy that you do. You don't, and you really shouldn't. But to make that decision, you have to have a good history, good physical exam, and good understanding of the radiographic parameters and appreciation of her or his balance. Because yes, there are some times in which you do a laminectomy and a patient with a flat back now becomes kyphotic. So my answer to your question is, it depends on the patient's symptoms and their radiographs, but not every laminectomy needs a fusion if there is no instability or preoperative deformity. I hope that answers the question.
Okay. Okay. There are other questions from the participant. One of the question is, what is your opinion about anterior approaches for spinal deformity correction, especially with the expandable cages?
Yes, and I think as we mentioned, thank you, that's a very important question. I like anterior approaches. I like ALIFs. I like L4-5, L5-S1 ALIF, especially if I don't have, if it prevents me or doesn't make me need to do a posterior 3-column osteotomy. That's more morbid in my hands, more blood loss, more deficits. So I like the ALIFs for correction of lumbar degenerative deformity. What I don't like is what a lot of people are doing, and that's just my personal opinion. I don't like people that do what's called the hybrid procedure, which is 3, 4, 5 level anterior or lateral and say MIS, but then in the back they open big T10 to pelvis. For me, that doesn't make sense. It's not an MIS procedure if you open the person's back from T10 to the pelvis. So the anterior approach has a limited role, but I do like it for the lower lumbar spine to achieve good lordosis between L4 to S1.
Okay. Professor Abbad Sharif Asri, Dr. Ahmani, Professor Abbad Sharif Asri, who raised in hand, and then after then Hilmani.
Assalamu alaikum. Good morning. Thank you, Dr. Wahabi, and thank you, Dr. Ali Baaj. I want to say we miss you, Dr. Ali. And my question is about, do you think with the emergent techniques of anterior realignment, like OLIF and X-LIF, do you think that these techniques will reduce the need of a posterior approach, like osteotomy, SPO? Thank you, Dr. Baaj.
Thank you, Dr. Abbad Sharif, and I miss you too. That's why I'm here, because I miss you very much, and inshallah we see you again soon in person. But the answer is yes. The answer is yes. There's no question that the anterior approach and the lateral approach, help and make it less necessary to do major reconstructive surgeries from the back. The answer is yes, they do help. How I use them, for me, if I do a lateral approach or an ALIF, I really like to keep them as part of the MIS package, what I call the MIS package. L4-5 or L5-S1 grade 1 spondylolisthesis or grade spondylolisthesis. Do a beautiful ALIF with percutaneous screws. That for me is part of the MIS package. The only thing I don't agree with is if you do 1 or 2 or 3 level lateral and you expose the patient to the complications of a lateral, then still in the back you go and do major osteotomies. I don't think you should do, my opinion, this is just my opinion, I don't think you should do both. Either do it open from the back or keep it MIS package.
Okay, Professor Hilmani. Professor Hilmani.
Yes, thank you, Professor Wahabi, for I would like to ask about 2 questions. First, for sacro or lumbo iliac fusion. So when in what indication we use these techniques first, and for training for beginner residents, when we haven't neuronavigation, how your message or your parents to give to all of our panel to avoid complication perioperatively when, especially when the vertebra is rotated. Thank you.
Yes, of course. Professor Helmani, thank you. Just to be sure, the question is about the S1 and pelvic instrumentation. You're not talking about fusion.
Yes.
Okay, yeah. So the indications are clear for pelvic fixation, right? If you have a high-grade L5-S1 spondylolisthesis, if you're doing a major correction of lumbar degenerative deformity and you need to anchor at the thoracic spine, you should go down to the pelvis. You know, those are two. And of course, if you have distal junction DJF, let's say you have sacral insufficiency fracture or pseudoarthrosis at L5-S1, non-union at L5-S1, those are 3 or 4 of the common indications to extend to the pelvic fixation. It's, you know, I tell my residents, the largest pedicle in the body, the largest pedicle is the ilium. The iliac is huge. It's the largest pedicle in the body. And I train to do them freehand traditional iliac bolts. With navigation or X-ray, the S2 iliac screws are now more popular, and that's what I use now because I don't have to do as much dissection along the lateral aspect of the sacrum. So if you don't have navigation, there are several very nice videos. I can email you very nice videos online and techniques on how to very, very safely place iliac screws. Those are actually safe to place. The dissection is a little bit painful. The S2 alar iliac are a little bit more challenging without fluoro or without navigation. But we can, you know, I'm happy to do maybe even another talk just with your residents on techniques or show you the videos for those.
Dr. Hakou?
Thank you very much, Professor Ali, for this excellent presentation. After you visiting Professor Lotfi Miladi, have you changed your philosophy to treat the pediatric scoliosis? What is your philosophy now? You fuse or not fuse?
Yes, thank you very much, Dr. Al-Mahdi. You know, I love Dr. Miladi. He was very gracious to me, and he really taught me a lot about the concepts of pediatric orthopedic scoliosis. But again, I think he's right. You should be minimally invasive in a lot of ways. I really like his lumbosacral construct for neuromuscular scoliosis. I think it's very minimally invasive. As far as do you do the fusion or not, it's again, that goes back to what is the standard in your area and in your region. So if I do all of those surgeries without any arthrodesis, that may be a little, and I have multiple, let's say, rod fractures, that may be open to critique from a lot of colleagues. So the standard in the United States, if you're doing a posterior base approach for scoliosis correction, is either growing rod construct or definitive fusion. So I don't mind not doing a fusion, but I have to counsel the patient and the parents that this is part of a growing rod construct and you will need ultimately a fusion. But I love my time with him and he really teach me a lot about pediatric orthopedic scoliosis principles.
If we can put our keys now, I will share with you the pool. You see it?
Yes, we have 3 questions. We decided to ask just three very easy questions to the audience based on our discussions, and I know everybody will get 100% because we talked about them in the talk and also in the question and answer session. So there are only 3 questions.
So we ask all the panels to answer.
And you don't have to worry. We don't know who answered what. It's anonymous. And for sometimes if you can't answer on the poll, you can also write your answer in the chat box, what's your choice. I don't know, maybe the audience cannot see the poll questions?
No, it's
we can't vote.
It doesn't work. We can't vote. It doesn't work. We can't work.
Okay, I will share.
There is no access to the screen.
I will end and I will.
Maybe.
Excuse me. I will share it now.
So basically the question is for the audience that if you can still, the first question is, what's the best indication for a 2-column osteotomy? What's the best indication for a PCO? And of course, the answer here is a lumbar deformity.
Okay. You can.
Oh, you got it?
Yes.
Oh, okay.
Okay. You are allowed to vote. I don't know if you can
No.
vote now. No?
Mehdi, we can't use vote.
No, it doesn't work, Mehdi. It doesn't work. There is some problem with the. So.
Well, I can answer. I'm happy to answer.
Yes.
So the first question.
Now? You can't vote now?
No. I think yes. Now, yes, it's working.
Now.
Yes, it's working.
It's working.
Okay, thank you.
You can read the question, Professor Ali.
Yes, the first question is what's the, and I see here people starting to vote. The first question is what's the best indication for 2-column osteotomy or PCOs? This is a hard question, and it's really all of the options can be correct, but the best indication is C. It's a lumbar deformity with open disc spaces. If you have a rigid fused deformity, a lot of times you need a 3-column osteotomy. And the trick question is the second one. If you have a flexible cervical deformity, sometimes you don't even need to do osteotomies there because it's flexible. So the best answer there is a lumbar deformity with open discs. Now, number 2, which of the following is important workup in elderly patients needing reconstructive deformity correction? And
let's the panel's answer.
De que desgaste de hueso.
¿Pero qué le molesta a usted?
Me molesta, no me deja caminar. No.
Let me know. I'm happy. You tell me, Dr. Al-Mahdi, when you want me to discuss it.
Okay. We have three answers.
It's done, Mehdi?
Yeah.
It's done? No?
Yes.
You have already the answer here.
Yes, we have 3 answers. So you can go, Professor Ali.
Yeah, so number 2, the point of number 2 is to make you aware that you really need an MRI, you need the standing scoliosis films and the DEXA scan. The answer is all of the above. All are important in evaluating patients that need major reconstructive surgery because you need the MRI to tell you where the stenosis is, where the neural element, what's going on with the neural elements. The X-rays tell you the deformity correction and angles, and the scan tells you if the patient needs osteoporosis treatment or not before your operation. That's question number 2.
Okay.
And number 3 we talked about a lot is if the balance looks okay and the lumbar lordosis to PI ratio look okay, what do you, if you have a high pelvic tilt, what does that tell you? And I think everyone will get this one right.
We don't have the third question here.
Yeah, you're getting a lot of people vote now. And I think everybody, almost everybody will get this question right.
So I want, you can go, Professor Ali.
Yeah, what we're trying to say in this question is, if you have somebody who comes in with a very high pelvic tilt, they may give you a false sense that they're balanced, but they're probably not balanced. So it can give you the impression, or it can indicate that they have both a false normal balance and they're doing compensatory pelvic retroversion. So the answer is D. It's A and C. Both of those are true. And that's why it's important to measure the pelvic tilt in all, when you look at the lumbopelvic parameters, to make sure it's a true representation of the balance. Thank you, Professor Mahdi. I hope the audience found this to be useful, and we're thanking for the invitation.
You have some minutes for other question?
Oh yeah, sure. I have 5 minutes. Yes, of course.
There are some questions from the audience. Yes. Maybe. Okay. There is one question from the participant. For thoracic kyphosis, do you have to do somatotomy?
It depends if the thoracic kyphosis is, it depends on where the ankylosis is. If, you know, for example, if you have a Scheuermann's type of kyphosis, then you don't need, all you need is a PCOs, posterior column osteotomies. If you have multi-level fusion of the vertebral bodies and with a fixed angular kyphosis, then you have to do a VCR or a PSO, which is a vertebral column resection. So it depends if the vertebral bodies and disc spaces are fused or if they're open.
There's a question by Dr. Brahim Kamoun. Did osteoporosis represent a limitation for surgery?
For major reconstructive surgery, if I'm doing 5, 6, 7 level fusion, yes, I do not offer that to patients with osteoporosis unless they have at least 3 to 6 months treatment of with osteoporotic medication. If it's osteopenia, I'm okay with that. Osteoporosis, I don't offer major reconstructive surgery. There's a high failure rate with that.
Okay. If there is any question, Mehdi? No? Okay. If there is no question, thank you very much, Dr. Ali. Thank you for your presence with us. And it was very, very interesting, practical. And thank you for being with us. Thank you also for the Moroccan Society of Spine and Spinal Cord, Professor Hilmani, Dr. Hakou, all the members of the Moroccan Society of Neurosurgery to be here. And thank you very much. And see you for the next webinar, maybe very soon.
Thank you, everyone. It's a pleasure. Thank you, everyone.
Thank you, Professor Wahabi, for this very nice moderation to get success this session. And sure, Professor Ali Baaj, I would like to thank you on behalf of the Moroccan Spine Society and Spinal Cord Surgery Society to have with us as one of the most Haiti in presentation. I would like also to thank my friend Dr. Mehdi Hakkou for his technical support, and many thanks to all participants around the world. We have near than 100 participants from Africa, from Asia, from Europe, from USA. I am very happy to see them in our webinar, and I tell you, very nice of Ramadan, and I wish you a good Eid, inshallah. For I think it will be on Sunday, and stay safe in your home, in your work, and wish from Morocco. Thank you very much.
Thank you, Professor Hilmani, for this coordination, and thank you, Professor Wahabi. Thank you, Professor Ali Baaj, for this very, very interesting presentation. I would like just to announce the next webinar is with Professor Linky, posterior osteotomies. It will be 26 May. So we have pleasure to invite all panel to participate with us. And thank you very much.
Thank you.
Thank you.
Bye.
Take care.
Hi, Ali.
Thank you.
Bye.
Thank you, Mr. Wahabi. Mehdi.
Sisi Hilmani, تبارك الله عليك.
Thank you. We have some no Moroccan participant. You can talk in English. Thank you.
Thank you very much. تبارك الله فيك.